All right. Hello, everyone. My name is Kate Marquis. I'm a nurse at the UVA Life Support Learning Center. And today we are kicking off our sensory assessment series, and we're going to start out with sight. So objectives, again, this is part of a series. You're going to get another 3 videos from me after this. Our objectives are to identify 2 ways that each of the following senses can influence the assessment of our patients. And today we're going to do sight, but we'll get through almost all of the 5 senses. I left off taste. I think that is completely reasonable. Shouldn't really be tasting your patients. It's not something I recommend by any means. So why a sensory assessment series? It's kind of weird. We got numbers, we got blood pressure cuffs, I got ECGs, I got 5 leads, I got pulse oximetry, I got waveform capnography. Why do I need to use my senses when I have all of this data coming at me? Well, it's really interesting because you can gather a lot of information about the patient's condition before we even lay hands on a patient. And when you look into classes such as the Emergency Nurses Pediatric course, the Trauma Nursing Core course, even Advanced Trauma Life Support, and the like courses for pre-hospital and otherwise, we actually talk about what's called an across-the-room assessment. And that's beginning to utilize your 5 senses or 4 of your 5 senses to go and get information about this patient and determine whether or not I need to act immediately or if I have a minute to kind of think about what I want to do next. Further, vital signs, all that information that we're getting from our equipment and our technology they're simply points on a graph. Okay, and they're kind of, in a lot of ways, meaningless until I know what the patient's baseline is. Now, if my patient's blood pressure is 70/40, and they're a 50-year-old adult, I can guess that that's probably not what their baseline is. But otherwise, you can have someone decompensate in front of you, and otherwise they look like normal vital signs. So someone's blood pressure is 130/80, and then the next one is 120/70, and the next one is 110/60. These are all what we would consider okay blood pressures, but really there's no context. I can't see that deterioration until I look at all of that information together. So this is something you can certainly use in conjunction with all of those numbers that may give you a better indication about kind of where that patient is trending before I even have to go and rely upon these vital signs. Additionally, there's always equipment failure, things that we kind of have to contend with, thinking about the accuracy of our machines. I don't know if you've ever seen toothbrush VFib. So it looks like VFib on the monitor there, and everybody and their brother busts into the room and the patient's just sitting there brushing their teeth. I've had that happen before. Or maybe your blood pressure cuff isn't reading, or maybe the pulse oximeter is sitting next to the patient on the bed and it's still reading 99%. So these are all things we need to kind of keep in mind, and being able to go in to look at your patient and to kind of have an idea of where I need to start will really help you in your assessment of your patients and your identification that your patient is potentially deteriorating or is kind of in a bad place before you even go in and put numbers on. So let's talk about sight. Sight is one of those things that we can do at a distance. So if I'm the triage nurse or if I'm the EMT in the field, I can see my patient as I'm walking up onto the scene, or even if I'm a physician standing at the doorway or doorway assessment there. This is going to provide clues about our patient's condition and potentially their safety status. So there are a lot of insights that we can have here. The first one is altered mental status. And when you look at both pediatrics and adults, they kind of take this into consideration with appearance. So what does the patient look like? And this one, we're a little bit more specific here. So are they altered? Are they acting normal for their age? Now, a 3-year-old, for example, I would expect to be kind of running all over creation, getting into things, exploring. Whereas, maybe my adult, I would think that they're going to kind of sit quietly in the corner waiting for their turn when I'm the triage nurse. So are they acting normally? Or are they altered? Is my 3-year-old lying limp in mom's arms? Is my adult agitated? Agitation is an early sign that the patient's mental status may be deteriorating. whether that's from hypoxia, hypoglycemia, or the like. There are a myriad of different things. So agitation in an adult patient is something that I really get worried about. Additionally, that's a safety concern for me, right? If I'm the EMT coming up on that scene, if I'm the nurse coming up in my triage bay, if I'm the physician looking at the room, I'm looking and I can see my patient is agitated, that puts me at risk if I'm going to walk into that room. So things to kind of keep in the back of your head. Breathing. So this can show us signs of poor oxygenation, compensation, or decompensation. So what I mean by that is I can see if they're becoming cyanotic. You're looking for that circumoral cyanosis. You're looking for just cyanosis in general. I'm looking for accessory muscle use. I'm looking at their actual rate of breathing, whether or not it's too fast or too slow. And I'm really big on this, especially when you eventually go and put hands on this patient. Get an accurate respiratory rate. This is big, especially in the pediatric population, but in anyone in general, that's one of the first things to change. You're looking at sepsis, you're looking at some sort of hypovolemic shock. This is really going to be the thing that changes first. So everybody in the hospital has a respiratory rate of 16, 18, everybody and their brother. So go in, actually count that respiratory rate, take the time to do it. And I mentioned children. This is especially important in children. Children often wear clothes that they're not form-fitting, so it kind of hides their actual respiratory rate. So I've had this situation come up before where I've been told a child's respiratory rate is within defined limits. It was 20. Something, and that was an appropriate rate for that child, and I brought them back and I lifted up their shirt and their respiratory rate was actually 60. So that's 3 times as fast, if my math is right there. So get an accurate respiratory rate, look for accessory muscle use, it's very important, and just kind of take your time in that breathing, watching, because it will give you early signs of compensation or the fact that the patient has decompensated, much like that child did. Circulation, we look at gross injury, bleeding, stuff like that. So if someone comes in and they're tracking blood, most people move a little bit faster than if the patient was not, for obvious reasons. So I'm looking for blood on the ground. I'm looking for blood soaking through their shirts or their pant leg or whatever. I'm looking for obvious deformity. I'm looking for different kinds of bruising, battle sign, periorbital ecchymosis, swelling. You can see swelling pretty easily for the most part, depending on where you are. I'm also looking for signs of abuse. So it's an unfortunate thing that we have to think about as providers, but we are mandatory reporters, and if we don't think about it, then we will never find it. So I'm looking for bruises of different ages. I'm trying to think whether or not that bruise is appropriate for, in particular, it comes to mind a child of a certain age. So, would that 9-month-old have bruises along their shins? Probably not. Would the 2 or 3-year-old have bruises all along the shins of different ages? Maybe. You have to kind of think about that and think about the developmental stage as well, unfortunately. Moving on to neurological. These are some things that we think about: acting fast for stroke, as well as other neurological insults. So I'm looking for a facial droop, which may or may not be super obvious from a distance, but being able to see that patient smile with their teeth, which a lot of people don't like to do. They don't like to smile with their teeth, but having that full smile kind of open up is really important to kind of assess that symmetry. And then you can also look at pupil abnormalities. So do I have a really obvious balloon pupil, or is maybe the pupil a weird shape? Maybe even are my pupils just slightly off in terms of being the same size? They're not quite the same size there. So especially with pupil abnormalities, you have to ask the patient if that's normal for them. There's anisocoria, which percentage of the population has, where one pupil is just naturally a little bit bigger than the other. So looking at a picture of them, looking at their driver's license, I heard, asking them about it. Are your pupils usually look like this? Is this different for you? As well as doing a good assessment there. Or even if they have a pupil that is not quite the right shape? Have they had a previous injury before, or is that maybe why they're there? So these are all things that we can kind of go through and think about in our head, figuring out whether or not it's a new finding. Safety are also things that we can see. We can watch a person's gait when they walk up to us or we walk to them, whether or not they're having troubles getting up, what's their kind of strengths look like just from a distance. This will help us determine whether or not the patient is a fall risk, which is super important in the hospital setting. Also helpful to know pre-hospitally. I need to know whether or not my patient, if they're able to walk to my stretcher, if I shouldn't let them walk to my stretcher, if I should bring the stretcher to them, because it can further complicate whatever problem they've called you for. Additionally, we can look at social aspects. So when I'm looking at my patient, how are they interacting with the people around them, and how are they interacting with their family members? Are they quiet? Are they subdued? Are they gregarious? What's normal? Thinking about the age group again, adult patients, I expect patients to act one way, whereas children with their parent, I expect them to act another way. Does the child look afraid? Does the adult look afraid of their grown child? Thinking about geriatric abuse, things like that. Additionally, how are they interacting with the people around them? Are they getting aggressive? Are they agitated? Are they just yelling at everybody? These are all things that I kind of need to keep in the back of my head. And then, does their behavior change when they don't think I'm watching? So this is something that I, as a triage nurse, I like to do, where I'll sit, in my triage area, and I can look out at the waiting room and assess everything and see how people are interacting with each other to assess, again, for these things. Does the behavior change? Does the dynamic change between the patient and their caregiver when they don't think I'm watching? So this is one part of our 4-part series here. I hope it was helpful. Next up, we're going to be doing hearing and sounds. So I hope to see you guys soon.